Hey, it's Rob Fitzgerald again. Thanks for tuning in. We're going to finish up our lecture series on adrenal cortisol and aldosterone, and we're going to talk about some of the disease states. So we're going to talk about Cushing's disease and Cushing's syndrome. That's an excess of cortisol. We're going to talk about Addisons, which is a autoimmune destruction of the adrenal gland, and so that would be hypocortisolism and hypoaldosteronism. And Conn's is also known as aldosteronism, so that's hyperaldosteronism, and sometimes called Conn's. And that can be primary and secondary, and so we're going to talk about the lab test to help differentiate those two. So Cushing syndrome is any excess of cortisol. So you can be have an excess cortisol. The primary cause is Cushing's disease, and as we've mentioned in some of our other lectures, that's a functional adenoma of the pituitary. So that adenoma is producing too much ACTH, acting on the adrenal to increase cortisol. That cortisol is not effectively feeding back in the negative way on the adenomatous tissue. And so you get an increase of cortisol. And that's about 70% of the causes of Cushing syndrome is Cushing's disease. Less is ectopic, so those are neuroendocrine tumors. So these are tumors that have structure and originate from a neuroendocrine type of gland. And they're secreting ACTH. They're not subject to the negative feedback, so that ACTH is acting on the adrenal, increasing cortisol, and so you have hypercortisolism. You can also have tumors in the adrenal gland, and so adenomas are the most common, and they are producing cortisol independent of ACTH. Carcinomas of the adrenal are fairly rare. And so previously we talked about the effects of cortisol, and if you understand the effects of cortisol, you can understand the clinical findings. So truncal obesity, moon face, and buffalo hump are very characteristic findings of Cushing's that's related to the redistribution of fat. Abdominal striae is caused by the truncal obesity, so you stretch out skin and you get stretch marks. Muscular weakness and osteoporosis are related to the catabolic effect of cortisol. Hypertension is due to the effect of cortisol sensitizing arterioles to norepinephrine, so that's going to make patients hypertensive. These patients also have disorders with their androgens and estrogens, so they get hirsute, they get virilized, they get diabetes because cortisol is a glucocorticoid, and so they're going to have an excess cortisol. What's interesting, and one way to differentiate diabetes from Cushing's versus like a type 1 diabetic is a type 1 diabetic will often present as a metabolic acidosis with hyperkalemia. And so the acid-base picture is sort of the reverse here in Cushing's because of the mineralocorticoid effect. And if you remember, aldosterone does four things. It reabsorbs sodium and it reabsorbs bicarb. It excretes potassium and excretes hydrogen ions. And so in the setting of Cushing syndrome, cortisol is a glucocorticoid with weak mineralocorticoid effects. So when you have a lot of cortisol, you also get a mineralocorticoid effect. So you're going to reabsorb bicarb, you're going to reabsorb sodium, you're going to excrete potassium and hydrogen. So in that case, instead of being a hyperkalemic acidosis in type 1 diabetes and sometimes type 2s, you get a metabolic alkalosis with hypokalemia. So that's sort of the picture. So you can confirm Cushing syndrome, some of these symptoms by looking at electrolytes, and it has mineralocorticoid effects, so you're going to reabsorb sodium and bicarb, along with that water is going to be retained. Your potassium and hydrogen ions are going to be lost because you're excreting them. And so the resulting picture is sort of a normal sodium because the water is coming along with it, a low potassium, a low chloride, and a high bicarb. So tending to be a hypokalemic metabolic alkalosis. Glucose is typically high. It might not be strikingly high, but it's typically high in these patients due to the glucocorticoid effect, and that should make sense. Urea nitrogen is also high. You're breaking down proteins. That's the source of urea, and so your urea nitrogen is typically elevated. It's catabolic, so they're going to be muscle wasting, and they're going to be osteoporotic because of its catabolic effects of cortisol. Urinalysis, oftentimes you'll exceed the renal threshold for glucose, so you can find glucose in the urine. So that would be, hyperglycemia that's exceeding the renal threshold and spilling out in the urine. Addison's disease is destruction of the adrenal cortex, so we're talking about insufficiency of the adrenal gland. These patients typically are tired, they have weight loss, they have abnormal pigmentations and mental disturbances. So nothing really, shouts out that this is Addison's, and you can look at electrolytes and as well as measure cortisol and potentially aldosterone. So electrolytes, if you think about the opposite of what aldosterone does, if you don't have that, you're going to have a hyperkalemic acidosis. Glucose is typically low because you don't have any glucocorticoid effects. That should make sense. And urea nitrogen is typically high because they're hypotensive and they're not perfusing very well. Urea is your GFR is lower, so the time that urea spends in your tubules is longer, and you have better reabsorption of urea, and so you get an increase. So you can measure plasma cortisol. If it's normal or elevated, that rules out Addison's because Addison's is an insufficiency. Moving on to another insufficiency of cortisol would be congenital adrenal hyperplasia. So this is a genetic defect. There's many different forms of it. Essentially, it comes down to not having the right enzymes to synthesize cortisol. And the primary one that's deficient is 21-hydroxylase. 21-hydroxylase converts 17-alpha-hydroxyprogesterone into 11-desoxycortisol. And 11-desoxycortisol is used both to synthesize aldosterone as well as cortisol. And so 11-beta-hydroxylase hydroxylates and forms cortisol. A different enzyme pathway is required to synthesize aldosterone. But in 21-hydroxylase deficiency, the most common cause of congenital adrenal hyperplasia, you have a lack of cortisol and you have a lack of aldosterone. When you have a lack of cortisol, you have no negative feedback. And so if you don't have any negative feedback on your pituitary and your hypothalamus, your ACTH is going to jack up, and your ACTH is going to act on your adrenals to cause bilateral adrenal hyperplasia. And so what happens is that you get a big increase of 17-alpha-hydroxyprogesterone and other precursors which spill into the androgen cascade. And so women become virilized because they are synthesizing more testosterone because of the buildup of these precursors. And all of that really is related to lack of negative feedback of cortisol because you don't have the right enzymes. The best test for 21-hydroxylase deficiency is 17-alpha-hydroxyprogesterone. And so that one, there's really no overlap between normals when you have a 21-hydroxylase deficiency. Aldosteronism, sometimes called Conn's syndrome, is either a primary or a secondary, is the two most common causes. Primary would be an adrenal adenoma or bilateral hypertrophy of the adrenal glands. So these patients are hypertensive, and it's actually a reasonably common cause of hypertension that was not fully realized until more recently. And so, ruling out hyperaldosteronism is important in the setting of hypertension. So they have muscle weakness, they have polydipsia, they have polyuria. That's because aldosterone is reabsorbing sodium, and that's going to increase your osmotic stimulus. So you drink more, you pee more. The best test is a paired aldosterone and renin test. And so that's going to be useful for one, diagnosing both aldosteronism and helping figure out is it primary or secondary. And so the most common causes are secondary. There's a lot of things that, decrease GFR, which is going to increase your renin, which is going to activate your renin, angiotensin, aldosterone cascade. And by measuring both aldosterone and renin together, we can look at a ratio, and we can see what the driver is. Is it being driven by renin, which would be a secondary hyperaldosteronism, more common, or is it being driven by aldosterone, which might be a functional adenoma of one of your adrenal glands? So in primary, the plasma renin is going to be low because it's being driven by a tumor that's secreting aldosterone. So that would be a primary tumor in the adrenal gland. Secondary, as we said, more common than primary, is being driven by renin, and a variety of causes for that. This oftentimes leads to bilateral adrenal venous sampling. Sometimes these are microadenomas, and so they're hard to figure out where they are. And by doing very careful sampling of the adrenal glands and looking at both plasma renin and aldosterone, you can figure out is it unilateral or bilateral and which gland it's coming from. So that's a quick overview of Cushing's syndrome, Addison's disease, and hyperaldosteronism, and I appreciate you tuning in. Thanks.